Welcome everyone to Soma and Synapse. The interoception hour is what we are calling it. My name is Mike Ham. This is Dr. Mark Olson, an esteemed colleague and friend, and the two of us are engaged in a years-long acrimonious professional rivalry. No, actually, but an exploration, as it were, of understanding how the embodied nervous system works, especially in the case of therapeutic change or ritual experience. And we're both instructors in sort of different somatic methods. And so not only how does it work, but how can we teach the intricacies of the embodied nervous system? And this is a particularly relevant discussion today because we're going to focus on a kind of layered model of how basic sense input arrives as a conscious experience and how other things can modulate that in terms of the context and the mindset. And Dr. Olson, Mark, you're going to have a lot more to say about that. So that's my hope for this discussion. I hope that to invite any questions and comments from folks who are catching this live. Thank you for joining us. As well as get a chance, Mark, to learn from you in this way. You hired me as a teacher years ago, but I've had precious little chance to be in a classroom with you as the instructor. So I'm grateful for that opportunity. And we're going to talk about how the nervous system works in this particular way. So, Mark, any hopes that you have for today's discussion?
Well, I am really excited to see what comes out of our discussion because we've been having this discussion for a long time, and the model that you mentioned that I'll be sharing, certainly grew because of our interactions. And I'm just curious about what we can where it goes when we actually look at it and play with it and uh, you know tinker around. So because we haven't really done that. I've built the model based on a lot of our interactions, but we haven't really tinkered with it. So I think this is really fun that we get to do this for the first time live and see where it goes.
Cool. Do you happen to have that model handy so we can show
Yeah.
folks what we're looking at here?
Yeah. It's going to come in a couple stages. So I think the first thing that's useful to do is to just outline. I'm going to show a dynamic interactive model, but I want to first just show it in static pieces so it's a little simpler to build. So this is just a model of the ascending pathways for pain or nociception. And so you see you have A fibers and C fibers. A fibers are myelinated, C fibers are not, coming from various tissues, going up to the dorsal horn of the spinal cord. And then from there, they're going to head up to the brain one way or the other. The standard usual pathway that people talk about is the sensory discriminative pathway that goes to the thalamus and then up to the somatosensory cortex, S2. And the less well-known but equally important pathway is the affective motivational one that also goes to the thalamus and the brainstem, and then heads up to the limbic system, which is that little gray box within the cortical limbic box. So you have the amygdala, the insula, the anterior cingulate cortex. These are all different structures that are highly relevant to the pain experience and lots of other experiences when it comes to like having an emotional quality to it. So that's the basic structure of the ascending pathway. And you want to say anything about that at this point?
Yeah, it might be useful. So number one, that's I already learned something in terms of calling the one of them an affective motivational pathway. I want to hear more about that. Um, uh, I think I don't see the well, maybe we let us know, folks who are watching, if you can see the whole image being shared. Um,
Hmm.
but just to kind of briefly review, in case folks are still reorienting to like layers of the nervous system, um, when we speak of like these ascending pathways, there you can imagine a sort of a tissue being stimulated, and then different kinds of sensory fibers coming from the tissue into the spinal cord. And from the bottom of your model, the boxes at the bottom are, first you have tissue and nociceptors, meaning, sensors of tissue damage or irritation. And then dorsal horn, meaning the part of the spinal cord that receives sensory input. And then everything above that is kind of getting into the brain stem, the thalamus, here in the center of the limbic system, and then kind of insula, anterior cingulate gyrus, amygdala. These are limbic structures blooming, I guess, into the cortex, which we associate most with conscious experience. Is that an accurate kind of ascending review of the layers that we're talking about here?
Yeah, and we refer to each of those three levels as first, second, and third order neurons. It's the same way with any kind of touch system. And a lot of sensory systems are structured something like this, where it goes to the thalamus before it goes to the cortex. Uh, yeah, and you asked about that difference between sensory discriminative and affective motivational. Basically, if we were to cut one of those out and leave the other, we end up with a different kind of pain experience. So if we take out the affective motivational, I'm oversimplifying this, but we're just gonna go with that. If we take out the affective motivational, people will report that they have a painful experience that doesn't bother them. It doesn't, like, they don't care about it. It's
Right.
yeah, they know where it is, but they're saying I'm fine with it. They still call it painful, which is interesting. Whereas if we take out the affective motivational, sorry, if we take out sensory discriminative and leave affective motivational, people report that they have an unpleasant feeling, but they can't tell you where it's coming from.
Now, would it be an unfair thing to say one of these pathways, the one on the left that goes to the cortex, is like could be termed what you are feeling, and the one on the right is more like how you feel about it.
Yeah. So one's a what and one's a, yeah, how do you feel?
Right. Okay. And indeed, we notice in real practice that people have there might be a range of skills or predilections here, right? Some people might at least express more sensory discriminative precision, but may not be in touch with how they feel about it so much, versus other folks are very affected, uh, but
Mhm.
perhaps less acutely aware of exactly the borders of the sensation or something. And I might be putting too much on this particular model, but I'm curious if that also meshes with your understanding.
Yeah, absolutely. I don't have a research study to point to for that, but I think that's probably the case. Yeah.
Yeah.
I
Well,
think I would probably want to say that the effective motivational is a little more interoceptive than the sensory discriminative, because the sensory discriminative could be telling you that a snake bit you or something like that, but the effective motivational really tells you how you're feeling on the inside.
right. And so the emotional or motivational context is going to hugely modulate whether that pain feels like a threat, whether it feels like something your nervous system can say yes to, right? So it's really interesting to imagine, for example, rituals that involve pain, but people can get to a place where they embrace it, or they feel it transcendent via pain. Um, what is the motivational component, of or the affective component of pain? So already we have a sort of useful thing for anyone who's working with sensation in practice, trying to help someone, is that unless you are tracking different qualities or aspects of sensation here, and trying to break it apart, you might a person might be a little bit stuck in how they relate to their pain or their other sensations.
Yeah, we're going to talk a little bit more in coming up slides about orbital frontal cortex and prefrontal cortex, and basically which is going to be um, representing those like like what am I doing? Like what is it? What is this context all about? Is this a safe place? Is this not a safe place? Is it going to go on forever? Is it going to be just for a second? Because that helps us tolerate, right? If I know that this is just going to be a second long, I can handle it. But if it's going to go on for days, it's going to be more difficult. If I
Yeah.
don't know how long it's going to go on for, so that, it relates to what's my plan and what's happening around me. What do I know about that? So,
Yeah, you sound like people trapped in conversation with me. How long is this going to happen? People can tolerate it for a few minutes at least. So,
yeah.
um, well, Mark, let's see the rest of how this. So we're on ascending pathways, how sensory information goes into the nervous system, but there's a lot more to it. There's also modulations coming from the top down. So tell us.
Yeah. So you'll see in this updated picture here, I have the prefrontal cortex at the very top with PFC and OFC. By the way, the VM stands for the ventral medial prefrontal cortex, which is all about self. So like dorsolateral prefrontal cortex is about like remembering what you're doing, like, oh, I'm looking for my keys or something like that. Whereas ventral medial prefrontal cortex is usually about like what's going on for me. Um, Orbital frontal cortex is doing things around values and is this an important thing to be doing and that kind of thing. So, but you see two main new colors added to this drawing. You have purple, and this is the descending modulation pathway coming down from the brain, various parts of the brain down to the brain stem, different parts of the brain stem, and ultimately down to the dorsal horn, where it's going to modulate those ascending pathways. That's why I have that little circle there to convey that there's a loop it's going to come down the purple, and it's going to go back up the red, and they're just going to loop with one another. So I can modulate in an inhibitory or in a facilitatory way. So I can basically take those signals that are coming up, the gold signals, and then I can turn them up or turn them down. Or if you want to think of the red lines as being thicker or thinner, that's what the modulation process does. And all sensory systems do this, and this is just how it looks in the nociceptive system.
And Mark, would you just mind unsharing and resharing that image? I'm not sure if on the live stream, I'm not yet seeing the
Oh,
purple
okay.
lines come in, so I'm not sure what.
Let's try it out.
So we've got the ascending pathways, at least on the live stream so far. Aha, here we go. Yeah.
Oh, it shows up. Okay. Well,
So
apologies to our viewers.
no worries. So now, folks watching, um, we've been talking about, or perhaps there's just a time delay. So apologies if I've made you do this. But we've been talking about ascending things, and then Mark has just been reviewing how structures within the brain, um, based on the context happening, can alter how sensation is processed with descending signals. Um, and let me not stop you in your tracks, but I would love to hear you talk more about these aqueductal gray, retroventral medulla, this kind of brainstem level of the descending modulation.
Yeah, well, I mean, that's like next level geek right there. If we get into each of those structures, I don't think it's absolutely critical to dive into like what those areas are doing in the brainstem. I think it's just useful to think about. We're going down the brainstem, and then the brainstem is going on to the spinal cord. The brainstem, though, is a lot of medications for pain and anxiety are working at the level of the brainstem. So dopamine, serotonin, cannabinoids, all those things. When people take pain meds, it's often to modulate the the synapses there in the periaqueductal gray, which is PAG, and the rostroventral medulla, which is RVM.
Thank you. Sorry for the misnomer of the RVM there. The reason I got nerdy about that for a sec, and I suppose anyone tuned in uh, might might be similarly afflicted, is uh, that one interesting piece about the brainstem piece of like the volume knob of how intense or not the incoming sensation is that this is a place where change over time seems to be really important. For example, I've seen a couple studies on post-spinal manipulation. You get that adjustment, it feels good, or you go for a massage, it feels good. For how long? If it's a good session, oftentimes the biggest good feeling lasts for a day or 3 days maybe. And it seems like that, from imaging studies, seems like that span of time after a massage or a chiropractic adjustment or et cetera, may be due in part to an extended change in how that brainstem is processing pain. So it might be accounting for the decay in benefit from a massage after day 3 or something like that, is that your brainstem has reverted to a different setting. So anyway, it's an interesting place in terms of the cycle of pain perception over time. Similarly with migraine, for example, you have this big migraine, and clearly part of the migraine is an alteration how that brainstem is processing pain. What is associated with the cessation of the migraine attack is that these brainstem modulators have kind of normalized again. No longer are you feeling weird with every sensation in your body. So I'm fascinated by that brainstem level. Thanks for delving into the nerd part with me. Yeah.
Yeah. And I think that's so important. And it kind of, it's a prequel to things we'll talk about in a little bit about, how does body work change, or how does anything change pain? Is it because of something that's headed up, or is it something that's headed down, or both, some combination. So that's, we're touching into how the descending modulation plays a role in longer term effects.
Excellent. Let's come back to that, because I think that's one of those crucial questions, especially when pain is disordered over time. And you let me know, Mark, if I'm just putting a stick in your spokes with all these questions here.
Oh, I mean, we could do questions till the cows come home, right? So, like, no end to them. We could dive into. I think I'll just talk about what this pink arrow is, though, if that works.
Yeah.
Yeah. So the purple again is the descending modulation system, but the pink is endocrine and immune function. So that's going to come out of the hypothalamus largely. I think most massage therapists understand that we have relaxation responses that changes the hormone profiles, and those hormone profiles, as well as immune responses, are going to change how uh, all of these red and purple systems work, the signaling of those systems. So it gets significantly more complicated at this point, like how well these synapses are going to work, how it interacts with other neurochemicals. So you're basically just think of it as a soup, and the soup is affecting the brainstem, it's affecting the dorsal horn, it's even affecting things out of the tissues. So if you're having an inflammatory response, for instance, we're going to have a different kind of nociceptive situation than if you don't. That's the easiest one to talk about, but it's the same thing happening in the spinal cord and brainstem.
And something that I've learned in the last couple of years, which I'm absolutely fascinated by. What I understand you saying in this case, Mark, is that the hypothalamus, bottom of the limbic system, the top of the endocrine and autonomic nervous system, is a body-wide modulator of immune function, inflammatory function, autonomic function. Something else that is sort of influenced by the hypothalamus, of course, is the sympathetic nervous system, and something I didn't know when I went to massage school, but has at least in conceptual overview come into play recently, is a model from is more learning about how the sympathetic nervous system, motor outflow from the sympathetic nervous system, can modulate inflammation, sometimes in a tissue specific way. So meaning that specific sympathetic motor output can inflame a stomach or a patch of skin or a joint. And thus, perhaps we have an answer as to why somebody's disordered limbic system, might be generating or might be habituating inflammation, not systemically, but actually in a particular region. It's fascinating to me. So that's another aspect of that downward pink arrow. Yeah.
Yeah.
And I displaced your shared image, so I apologize, and I'll make room for the model again.
I think it's up now. Back
Okay,
up.
great.
Shall I go on to the like how it integrates with what we're doing?
Yeah, I would just love to hear about those outcomes on the right column as
Oh
well.
yeah, yeah. Okay, so I want to point out that all these colored arrows repres are not abstract. These are actual neural pathways. But the brown arrows are a little more abstract because we can just talk about what level of pain that you have, what level of affect, what kind of affect, positive, negative affect, how stressed or relaxed you are. So I just call those outcomes because they exist on a more subjective, experiential level, phenomenological level, rather than actual neural signals. And then spinal reflexes are, of course, very real. Maybe they shouldn't be brown. Out that all these colored arrows rep there's a little delay there.
That was my fault. Yeah, please proceed. It was just a little audio loop. Just making sure I was just testing you, Mark. Thank you.
All right, all right. So I was like, who's that? Oh, it's me.
What's that sonorous angel voice? Oh, wait.
Who's that annoying person speaking up here? So I think I put the spinal reflexes there to remind people that, that we have this focus and massage on muscles, but the muscles are just responding to what's going on in the spinal cord. So depending on, what the summation is of the yellow and the purple and the pink is going to affect what kind of spinal reflexes we get out to the muscles. So that's what those outcomes are all about.
And I think that I find it useful to have these layers of of outcomes, even if they're conceptual and phenomenological, because I'll be again, I'm a medical massage therapist. I'll be working on somebody trying to help them with their pain or their function in some way. And I will push on their back, and some layer of their organism seems to resist me. I'll push on their back, and their spinal muscles push right back. And I say to them, "Oh, I'm sorry." And they, from a conscious level, they are not in touch with any discomfort or threat perception. They honestly and earnestly will tell me, "I feel fine. Please proceed." And yet their spinal cord, their dorsal horn is talking to me with spinal reflexes, saying, "Back off, Buster," or something, right? And so it early in my career, I was confused by the mixed messages I got back from a nervous system. Uh, but in fact, it's not. There's nothing but mixed messages. Sometimes they cohere, sometimes they don't. But like my job actually is to find a way to have parallel conversations with a spinal cord, as well as with a limbic system, as well as with a cortex. And if I can do those in tandem, I'm likely to have the most sustainable and beneficial outcomes.
Yeah, and I think that's great to point out. That's a great segue to, how we affect at each of these levels. Should I dive into the visualness of
Please.
this? Okay. So everything, all the red and the purple and the pink is the same, but I've added some blue and some green and some gray to this. So let's start with the lower left here where it says any touch. Provide any kind of touch to the system. You're activating touch receptors at a neurological
Yeah.
level. Those are going to head up to the dorsal horn too, and then up to the thalamus and up to the S1. But at the level of the dorsal horn, they have the ability to suppress uh, the C fiber activity. So that's a ascending inhibition, we call that. And some people call that gate control theory, that providing touch can inhibit regular, ongoing pain sensations, technically ongoing nociception. And then I'm going to skip down to good pain. So good pain would be kind of basically the same thing. You're actually providing input that is nociceptive, and I'm guessing that it's always traveling on at least the A delta fibers, which are then, because they're faster, turn around and inhibit the C fiber. So, we talk about good pain all the time in massage therapy, and the whole idea there is that, we like it because it's inhibiting the achy C fiber based feeling that we have. So whether it's A beta or A delta, touch or good pain, that's an ascending inhibition. That's the AI effect there at the dorsal horn.
And I would imagine that this is uh, analogous to, I mean, here you are talking about, I think, mechanoreceptors in skin and other tissues. But I imagine that other sensory inputs can
Mhm.
also play a role in so proprioceptive inputs can play a role in this ascending modulation, or sonic inputs. I remember hearing stories about, in the centuries of dominance of the British Navy, you didn't have a lot of opium, to help people do tooth extractions, for example, on a sailing ship. And so what you'd have is the ship's drummer would go downstairs. You'd have, like, four strong sailors holding a person down. So some kind of descending modulation there, and then you'd have the ship's drummer start out a slow roll, and then, upon the instructions of the physician, be drumming right next to the person's ear at, right when the tooth extraction needs to happen. And I have not tried this myself, but
Mhm.
I hope to sometime.
That was my next question.
Um, uh, and I have had a wisdom tooth removed without anesthesia working all that well, which was fascinating. We can talk about that more. But so it sounds like when at these blue and green sensory inputs can be touch based, but they can also be other senses changing how pain is felt. Is that accurate?
Well, definitely the proprioceptive, because they're going to be going up to the dorsal horn too. And the um, the auditory that you just referred to, I think that's probably going to be an effect at the level of the thalamus.
Yeah. Yeah.
So, all sensory input goes to the thalamus except for smell. So, we can't do this with maybe not necessarily um, aromatherapy, perhaps, but the other ones could be providing a distracting stimulus. I mean, I could put a clothespin on your earlobe and you might not complain about the pain in your traps as much. Same idea. Any kind of, it could be pain input, it could be auditory, anything. So I think it's a distraction based effect.
That makes sense. And perhaps distraction is less precise than saying thalamic, input. I mean, in a sense, when we say thalamus, it's this kind of pair of football shape or egg shaped structures in the center of the brain, which receive a lot of sense data from below, and then route that sense data to various parts of the cortex. And this thalamus is so fascinating to me, especially when it comes to cross sensory modulation. Why? Again, because my brain is all about migraines and headaches right now. That's what I'm prepping for. Why do we become light or sound sensitive or smell sensitive during a headache? That's thalamic vigilance. We have a modulation of our thalamus that says ow, and also ow for visual and sound input. So interesting to imagine that the ship's drummer next to the sailor who's getting a tooth extracted might not have their dorsal horn being modulated, but may indeed have a certain amount of their conscious pain experience altered via thalamic input.
Yeah. It's the same thing when you're at a party and someone's talking to you and there's noise all around. It's the thalamus that's saying, please, turn up the volume, turn up the auditory signals that are tied to this particular location in space, and turn down all the auditory input that's coming from those other locations. So it can do that thing for space. It could do it for modality, sensory modality. It's all going to be thalamic based.
Cool.
Let me come back to that image, right?
Yeah.
So the green signal is your call hedonic touch or affective touch. This is what we get a pleasure experience when, like, basically an effleurage stroke or any kind of sensual, comforting stroke. It only happens at those speeds. So that's going to go up and affect the nucleus accumbens, which gives a pleasure kind of response to it. I don't think we, so that's like the basis of why the effleurage feels good. And whether that overrides the pain or it becomes a distraction or inhibits it, I'm not really sure. But we certainly have pleasure as part of the equation for massage and well, some types of massage. And then the last one I have down here, which I think you'll appreciate, is the moving the tissue to move the nerves around and provide maybe less mechanical uh, uh, duress to the nerves, so you have a happier ecosystem around the nerves, at least temporarily. And so that could change how much how active those nociceptors are to begin with. So
Indeed.
those are all the touch inputs that we could provide that I can think of. Maybe we can add movement to it. Um, that would work on a bottom-up way.
Great. Yeah, that makes sense. And so this here we are, and on this bottom left, this kind of these gray boxes are a kind of menu of touch inputs that we can use as kind of tools to change somebody's outcomes on the right, to change their affect, their pain level, their stress level, and indeed their reflexive output.
Yeah. Okay, and then over the course of the same time, while we're providing touch input, unless it's a robot, actually, even if it's a robot, there are also these more abstract relational social elements to it. So, and even the environment. So if you go into a nice spa that feels really, has nice music and nice smells versus you have one where the rats are crawling around, you can have a different sense about how safe this physical space is. And then the therapist is going to have a particular kind of social style. Do they feel safe to you and the way they talk and the way they touch you? So that therapeutic relationship is going to, both the therapeutic relationship and the physical setting are going to affect your mindset, which is also influenced by what you've learned before. What do you know about massage? What have been your past experiences with massage, or any past experiences that are relevant to this event? And those start changing immediately as soon as the therapist touches you. You start to form an opinion about, okay, I think this is going to go well, or I don't think this is going to go so well. And that changes your mindset, and that's going to ultimately affect these prefrontal and orbital frontal regions that give you a sense of, is this along the lines of what I want to be doing? Is this safe? Which is ultimately going to affect those purple signals going down to the spinal cord.
So the mindset, that all these, the physical setting, therapeutic relationship mindset, so much about how much descending modulation might actually be accessible in this particular context. And I pull two things out there. Number one, for oftentimes I'll have folks ask me about, to help them find a practitioner or find a clinic to go to, and they say, should I sign up for the 12 sessions that they want me to sign up for or something? And I'll say, you know what, it takes a bit of an ante up to see if you'll be helped, but I'll bet you that you'll know within 2 or 3 sessions at the most if this is going to be a helpful kind of therapeutic relationship, because by then this incredibly perceptive nervous system is you're gonna know whether your mindset is beneficially affected by the context and the ritual effects, etc. And if you're not, it's like, don't wait another 10 sessions. Cut your losses and go somewhere else. You'll know within a session or three at the most whether this therapeutic setting is going to be working for you.
Yeah.
Um,
Yeah. If you're gonna, yeah, go ahead. Yeah.
and the other thing that comes out for me here is, because I'm increasingly convinced, both anecdotally but also from the high level evidence, the meta analyses, et cetera, that one way that interactive healthcare actually like can collaborate or synergize with pharmaceutical healthcare is that with pharmaceutical agents, oftentimes there is an adaptive tolerance that can build up over time, right? So your nervous system, the same dosage might become less effective over time if just relied upon solely. Whereas for a therapeutic relationship, actually, if there's a good bond being formed, that can become more effective over time. So everything from guided imagery to any ritual whose groove can be deepened can actually affect these descending modulations more over time. And so there's a real, I think, short-term, long-term synergy when it comes to pharmacology and interactive healthcare.
Yeah, that's great. Thank you for pointing that out. It's a really good point. Um, I kind of want to jump in and show this in action. How does that sound to you?
That sounds great. And I just want to take a moment to thank, especially Sarah Lee, for all the lovely comments, and thank you for keeping us honest. And um, uh, you know, uh, there's lots of great comments from Sarah. I promise to get to them as well. But thank you so much for the interaction. This makes it so worth it when folks are watching. And Mark, folks are actually watching. This is great. Um, so let's see this model in action and start twisting some knobs in this grand organ that you've constructed, and see what happens.
Yeah. By the way, I just want to say, because I didn't say it before, that the reason I built this model is because you can always read about how X affects pain and Y affects pain and Z affects pain, and nod your head and say, yeah, that sounds good. I learned that. But then how does it all fit together? And so I wanted to build all this and figure out how it all fits together. So what you have here is it's going to be an interactive version of what we just saw before. We have the same red pathways ascending, going up, have the same purple pathways going down, same pink ones coming down. I can basically play God with an imaginary person here. So down here at the bottom in this orange, at the tissue level, I could specify what degree of nociception is happening in this person's tissues on a scale of 0 to 4. Right now I have it set at a 4 for that poor person.
How sadistic of you. Yeah.
Yeah, it's very sadistic. Yeah. And then I can affect the sensitization levels here on a scale of 0 to 4 too. And then up on the orange at the top, I can specify what that person's mindset is. Do they have positive conditioning experiences from the past or not? What are their conscious beliefs? What do they tell you about, the therapist? Or was it going to be good? Was it going to be not so good? What kind of therapeutic alliance is being formed? So all these can be adjusted to something negative or something positive. And then over on the left, I can talk about I can change the settings for the therapist input. So what kind of environment, are the rats crawling everywhere, or is it really nice music with nice aromatherapy going on? Are the relational skills good? Is the touch quality good? And you could put the touch quality somewhere else in this model, but I decided to put it over here. And then we're going to have all these different inputs that we could or couldn't provide. So we obviously going to provide touch in here, but I wouldn't have to do like an effleurage stroke, for instance. I could turn that off. I wouldn't have to do what you might call deep pressure, deep tissue, good pain. We wouldn't have to do things that might uh, change the situation for the nerves. So we could affect those independently. Um, Now, over on the right, I'm going to start, like this is where the client's intake comes in. They say, on a scale of 1 to 10, what level is your pain? So we're just going to say this guy or gal has a 6.
Can I
And
can I stop you for one sec there, Mark?
yep, yeah.
So okay, here I am, and I'm my hands are hovering over the treatment table, and I'm about to initiate a massage session with someone. And here I am at the bottom left of this model, and I've got this menu of options here: touch, see tactile touch, good pain, and sort of I'm trying to find it, I'm trying to see it in my Zoom, but reducing noxious input. If I were to just suppose here with my forearm, if I were to do the lightest possible touch and just do a moving brushing stroke, how would you characterize that in this model?
Just touch.
Just touch, right? So basically very feathery touch without any deformation, as it were, of the subcutaneous or other layers. Um, and uh, and then if I am actually sort of taking the skin with me and holding the skin or shearing the skin, but I'm attempting not to deform any like deeper tissues, is that kind of more the including the C tactile? Or how would so here I am just brushing strokes versus like actually moving the skin?
Well, any kind of gliding stroke that is, a kind of like a moderate speed, effleurage speed,
Yeah.
would turn on the C tactile. And then the first one you did, I think, was too light because that's almost ticklish feather
Yeah.
strokes. So, um, but if you're grabbing the skin and you're moving it like that, I don't think that would be a C tactile touch.
Right. So I
Yeah.
mean this is important just because, there are medical situations where my menu might be more limited, right? If I've got someone with advanced osteoporosis, for example, they might really benefit from a massage, but I might have to not put almost any pressure on them, right? So versus somebody, or a newborn child, right? What am I going to have available to me? I'm not going to do some good pain with a newborn. So um okay, so thank you for helping me get my head around that. Yeah.
Yeah, yeah. Thank you. Um, So just so everybody knows, on the right are the client's, initial states and final states. We're gonna get to the final states after we run this, but the initial states, I'm just picking 6. I could pick any number here. But what's their affect? What's their mood? Are they having a good day? They feel good or not? I think you can have negative or positive, so it's a negative 10 to 10. Stress, you could be stressed or you could be relaxed. So I put that into a negative 10 to 10 as well. And what level of spinal reflexes does this person have as a baseline? So I'm reducing it to a 10 scale, right? Which is limited, but it's a place we're just going to start with. So just with these settings, I just want to show what happens here. I'm going to do a 60-minute session, and we'll just sit here for 60 minutes and watch it. No, I've reduced it down to like 30 seconds for a 60-minute piece here. So I'm gonna hit the massage button, and what you'll notice is that for the first 5 minutes of the session, they're just talking. So you're just getting relational input, no touch input. So you're not going to see touch input happening. And then once the touch input kicks in, then you'll see how things change. Now I've got everything set at a negative place, biologically negative, socially negative, therapist negative. It's like the worst possible massage session and condition that you could have, but we're just going to start with that. I think it's a good place to start. And note that in order to get these outputs to happen, I had to play God. I had to decide how all these numbers are going to fit together and create equations, which of course, the equation for me is going to be different than the one for you. And like me today is different than me tomorrow, probably. But I've tested this and come out with outcomes that I think generally match what I would expect in those kind of situations or what I've seen in those kind of situations. And these are all nonlinear equations. So it's not just like a little more gives a little more. It's a much more complicated thing. So here we go. I'm just going to hit the button and hold your breath. See what happens. So they started out as a 6. I'm just going to look at the pain. Notice that the pain level is going up. And I don't know if that would always happen, but I kind of think that if you had a rat infested room and your therapist was, you know, not a very good communicator and they were doing a terrible job touching you, you'd probably walk out feeling worse. So here we are at 50 minutes. Yeah, this person isn't coming back.
This wasn't their style, I mean,
No.
you got to find your ideal rat infested, rat positive clientele.
Yes, that's true. That's true. We could add that as a setting, of course. So, from here we could do different things. We could just change one of these settings. Do you have any particular favorite? What strikes your curiosity, Mike? What you
This
would change?
I love this, Mark. This is like playing a board game. This is, you're not playing God, you're playing game designer almost.
Yes.
Um, all right, I want to keep the therapeutic setting terrible. So I want this to be a real dump, and I also want to keep the therapeutic, the relational skills of the therapist abhorrent. But I want to just take the conscious beliefs to the max. Like, I just want there to be uh so the therapeutic alliance, I want to have very negative, like no alliance. And I also, let's have no agency, like no sense of control over your experience. But I want your conditioning, you really consciously and unconsciously believe that this will help. And I want to see what changes when we do just those two things.
Just those two things. Okay, here we go. I don't know what's going to happen. I haven't tested this exactly. So things are getting worse in just about every way. They're not getting as bad, and they're not getting there as fast, or maybe they are getting there as bad. They got there slower, I think.
Now, interestingly, like, that might change my beliefs next time I come back, if I come back. But it sounds like just positive affirmations is not going to do enough to modulate my pain experience here, or my mood, or my stress.
The rats go a long way, so
Yeah.
yeah.
Well, can we try the same thing uh, with just making the environment neutral? So like neutral environment, um, and like neutral relational skills, but still like bad touch.
All right, keep it there.
Sure, why not?
Okay. All right, we'll do that.
So that seems almost as bad as the last time, maybe even.
Does seem almost as bad, yeah.
Um, and I have one last one. So let's say that there is let's make the touch quality as good as it can be.
Okay. I mean, and I think this makes sense, right? If you had high expectations, but the touch quality was really poor, you wouldn't come out of there feeling
Right.
good about it. Right. Okay.
Well, let's suppose touch, yeah, the touch quality, yeah, sure. Let's just change that and see what happens.
Okay. Yeah, things are going better.
Things are going better. I love the durational aspect of this, by the way. You play this out minute by minute. Um, uh, I might ask you about that. But it sounds like over the course of an hour, here we are 45 minutes in, pain has definitely gone down. We're in a much better mood. So touch quality counts for a lot, perhaps both independently, but also as a predictive affirmation, I guess, of what you believed might take place.
Yeah, and by touch quality, I mean, is it resonant and attuned? I don't mean that they had 1,000 hours of training or something. It just means that it's attuned to what the client's body is wanting.
Right. I mean, I think sort of often I am reminded to teach and to tell myself that, you know, our skin, of all the functions of skin, you know, when you teach integumentary system, we forget how much the skin is for mammals a communicative organ, and how how dialectically specific the skin can be, how the ability to learn the local dialect when you touch someone is, which I take to mean attunement, right? Like when you learn how quickly can you arrive at what safe and welcome touch is with a given person, I think is what you're talking about with touch quality.
Yeah, yeah. You mentioned about the time element here, so I should mention that if I were to make the model better, it would the orange part of the top, the social part of the top would respond as we go along, because that's what would happen, right? Someone touches your traps the way you want them to, and now you've changed your mindset about the rest of the session. This model doesn't do that. It's not that sophisticated, so it just starts out with a particular mindset and it sticks to it. But in real life, of course, it would modify as the session would go. Um, should
Right.
we play with any other settings?
um I, I think what I'm curious about here is like, uh well, number one, I just wanted to zoom out and say, here, Mark, you've built this game board, and there's a certain amount of playing God or arbitrariness in terms of deciding on, you know, like a single dimensional scale of like unconscious conditioning, or, you know, -2 to +2. But I want to acknowledge and celebrate um, what's true about this model, which is not true about most, I'd say, teaching models of manual therapy, including my own, which is, I think you have applied a pretty rigorous standard when it comes to the pathways to try to be both accurate and exhaustive of what is known, so that you've really, you know, said, I'm going to try and build this from what we really truly do know about the pathways that exist, both ascending and descending. So that part is just, uh, I think, I just want to acknowledge that there is a real rigor there in terms of trying to go to make a game based on the real, the incredible, you know, a century's worth of hard labor from the world of academic neuroscience, uh, and and then from that, uh, we're seeing, we're playing a sort of board game, based on meaningful layers here, and so I think for me the impact of playing with a model like this is less that I will be able to totally predict what the real world change will be for a person, but that I, by playing with different parameters and seeing things play out over time, I'm training my own therapeutic decision process, to know that I have choices, and to know that those choices might play out over time. And in fact, that if I see things traveling in the wrong direction 30 minutes in, I can change. I can zoom out and say, wait a minute, is there, do I need to tune up the agency that this person has? You know, like halfway through a first session with someone, they're going through what they think is the ritual requirements, and maybe all it takes is a sense of, hey, let's just take a breath, let's take a movement. Are you comfortable in your body right now? Is there anything we can do to change your comfort level? Just a moment of agency. Maybe I've bumped that up a couple notches. So so to play with parameters, to know that in fact you have choice points throughout a session, and this may not be a bad menu of things to keep in your mind as you're doing work with someone, whether it's touch based or movement based or talk based.
Yeah. Yeah, absolutely. And you know, in building this and watching it work, I've certainly seen how the touch inputs have powerful input, and also the relational inputs and the mindset is equally powerful in terms of the outcome. And you don't the touch the way I coded this is the touch inputs aren't going to do really anything if you have poor relational inputs. So things get really good once you reach a kind of just a zero level on the blue side. The touch inputs can go really far, but if you're in the negatives in the blue area, the touch inputs aren't gonna go anywhere.
So uh, so in I think it's a good moment for us to kind of like zoom out a little bit, and for me, at least my question here, Mark, is now kind of talking, because my hobby horse these days is to talk about ecology, right? And especially when it comes to how we understand the changes over time uh, in a human system, in a human body. I think a lot about the world of restoration ecology, you know, because uh, the way that I was trained, initially at least, seemed to kind of come from a, a mechanistic idea of how a human body worked, to say like, okay, if you can get the body shaped just this way, you can predict how in pain it will be or not. You know, I remember seeing a poster at a chiropractic office once that was like, you know, subluxation is always, of course, a cause of disease or something like that, right? And it's uh and like that's a very deterministic idea of of how uh of how humans work. And in fact, it's actually not accurate, right? In fact, even if you knew, suppose you were able to refine this model, Mark, to the point uh, where where you know you could explain very precisely that, you know, a real session, and it would match up with the outcomes of the real session. Even then, I think you wouldn't necessarily be able to predict the outcomes for the next person that walks in the door, because ecosystems are emergent. So if you're trying to, for example, help restore a watershed, um, you know, in your local forest system, uh, you can really understand the components. But even if you had perfect information, you wouldn't necessarily be able to predict how next it would go. So as an example of this, I want to get your thoughts here. You know, uh, here's an old picture from, I think, Ramon y Cajal, about, you know, the ascending layers of the nervous system. So here we've got our spinal cord inputs and our modulations in the brainstem and thalamus. And of course, I'm sure this has been updated lots of times. But in complexity, in biology, this is kind of a schema that I think we see happening in this model too, which is that we have lower level entities that are interacting with each other, like tissues and nociceptors and receptors. We have then those produce an input that goes up to these higher level entities, which play by their own rules, but then also influence the system below, but also send inputs to the next level, which again plays within itself and also sends information up and down. So all of those are kind of layering. You might hear a dog barking because I've got a very enthusiastic dog upstairs. My concluding question for you, Mark, is if you can't predict exactly how someone's nervous system will be modulated, what is the value of a model like this? I have my own answers to this, but suppose you're trying to restore a watershed or replace an invasive species in a forest, or indeed change somebody's pain state or stress state. What's, and assuming that their behavior is going to be always emergent to some degree, unpredictable to some degree, why have a model like this?
Well, because it forces you to be curious about where things are coming from and where you can tap into the whole system. It's, if it's just X A to B or X to Y, then, you're missing out on all that complexity. So having these emergent layers, or not even emergent necessarily, just different layers, gives you different places to plug in. You can plug in at this tissue level, you can plug in at this social level, the mindset level, chemical level, immune level. I mean, there's all sorts of levels. And you got to be curious. You can't assume that what worked for the last client is going to work for the next one, because they may both say they have a 6 on the 10 scale of pain, but one's got a 4 on the biological uh, setting, and another one's got a 2, but they've got different, purple descending modulation going on, and it changes all the final outcome. So yeah, you got to figure out how it all fits together, and you can't do that because you can't see it. You have to explore, and you have to be curious find to find your way.
I think curiosity and sort of respect for this this amazing system that we have the gift of interacting with. I think that's a good place to end. Well, I think the plumber is here because my dog is going crazy and I have to descendingly modulate his behavior right now. So, Mark, I thank you for your time. This was a really fun discussion. For everyone who commented, Jennifer, Sarah, everyone who joined, thank you so much for your inputs. This was a fun discussion. Please share this live stream if you thought it was cool, and please check out both Mark's page, Dr. Olson, as well as following Nerve and Soma. And we hope to do this again sometime.
Sounds good. Thank you.
Thanks, Mark. Have a great day.